This section will focus on recovery-oriented systems of care, providing some history of how recovery-oriented systems developed over time, defining the concept, and describing both underlying values and operational elements of a recovery-oriented system of care. This information is drawn primarily from William White's paper entitled Definition of Recovery, 2010 Recovery Summit, which is included as an attachment, and the book The Roots of the Recovery Movement in Psychiatry, Lessons Learned. A full citation list is detailed on the last slide of this module. In 2010, the Substance Abuse and Mental Health Services Administration, or SAMHSA, defined a recovery-oriented system of care as a coordinated network of community-based services and supports that is person-centered and builds on the strengths and resilience of individuals, families, and communities to achieve abstinence and improved health, wellness, and quality of life for those with or at risk of alcohol and drug problems. Today, this also includes individuals experiencing or at risk of experiencing mental health disorders. Recovery is not about the elimination of disability, but rather to live life to the fullest, even in the face of continued limitations. People want to recover lives worth living. Goals need to be reframed to move beyond clinical stability and embrace whole life recovery. What do we mean by a life worth living? Consider the table on this slide. Why is it that the things that we expect for ourselves have traditionally not been represented on the treatment plans of the individuals we have served in the behavioral health system? Why do we expect that a person experiencing psychosis or depression is striving only to stay out of the hospital and not to also be a good spouse or parent? Recovery-oriented systems embrace the whole person and utilize the strengths and expertise inherent in each person to recover a life that the person believes is worth living. To understand the roots and importance of the modern recovery movement, it's helpful to briefly review the history of mental health care over the last several hundred years. Prior to the establishment of mental institutions, or asylums, mentally ill people were often placed in jails and prisons where jailers assumed they couldn't feel the cold, heat, squalor, etc., as they were viewed as less than human and regarded more as animals. People were chained to the walls and beds, often had little to no clothing, and some laid in their own excrement. In the late 1700s and early 1800s, there was a movement in France for more humane treatment of patients, led by Philippe Pinel, who was aided by Jean-Baptiste Poussin. The movement was called traitement moral, or psychological treatment in contrast to physical treatment. These two men were pioneers in thinking about the best care for mentally ill people in France, and understood that having a sense of connection and purpose embodied recovery. They believed strongly in rehiring recovered patients from the asylum to continue to work there and aid in the treatment of the patients. Together they removed the shackles binding patients living in the asylums and punished staff who abused patients in the course of their work. They understood that giving the patients work was actually favorable to their recovery. They viewed people experiencing mental illness as more sensitive or with heightened sensitivities than the average person, and as capable of recovering a purposeful life in most cases. Similar movement, called moral treatment, was happening in England and then America, but it differed in that people with mental illness were viewed as childlike, where treatment focused more on morality and management of behaviors. Like Pinel in France, however, they believed in humane treatment and that abuse and cruelty only made matters worse. Both approaches shared the belief that people needed to be removed from their social environments to achieve recovery. As time went on and asylums were built in America to offer treatment, they were developed with the intention to have up to 200 patients at a given time. It was believed that this number would still allow for individual relationships with the providers and result in higher recovery outcomes. Unfortunately, these asylums came to be the dumping ground for people who were unwanted in the community, and included people with physical and developmental disabilities as well. As censuses increased into the thousands, conditions rapidly deteriorated and recovery rates fell drastically. As this continued, it was said that even prisons afforded inmates more rights and dignities than the asylums did to its patients. People had been committed to institution for years at a time, or even longer. Language began to shift from referring to people with mental illness as lunatics or maniacs to being described by their diagnosis: catatonics, manic depressives, paranoiacs. These people continued to be viewed as less than human or having lost their humanity. Mental illnesses were viewed as incurable. In the late 19th century and early 20th century, Adolph Meyer, and later in the 20th century, Harry Stack Sullivan had a profound impact on American psychiatric treatment, shifting the focus back to the person and trying to understand the person within their social context, recognizing their skills and desire to lead fulfilling lives. They recognized the humanity in people experiencing mental illnesses and influenced many pioneers in the field. They focused on outpatient therapy and treatment versus reliance on institutional care. A movement for deinstitutionalization occurred in the 1940s and 1950s. President Truman signed the National Mental Health Act into law in 1946, establishing the development of community-based care as a national priority. The buildings that housed the institutions were falling into disrepair and were overcrowded. Costs were increasing, and the deinstitutionalization movement was officially born in 1954. Over 20 years, legislation passed for creation of community mental health centers. Many people released from institutions ended up in the criminal justice system with untreated mental health issues. Treatment shifted to more of a medical, acute care model, heavily dependent upon medication and expertise of the provider. Services were typically of brief duration and focused on symptom suppression. Decision-making was primarily done by the provider, and relapse was viewed as non-compliance with treatment. The modern-day recovery movement grew out of former patients speaking out about the inhumane treatment they received and their desire for restoration of basic civil liberties in the 1970s. As systems shift now into recovery management, consumers are viewed as the expert in their own lives, and shared decision-making and a focus on the whole person are valued and promoted. A recovery-oriented system of care contains 4 basic underlying values. First is a person-centered approach, wherein services and supports are centered around the needs, preferences, and strengths of individuals. A recovery-oriented system recognizes that there are many pathways to recovery, including treatment, mutual aid groups, faith-based recovery, cultural recovery, natural recovery, medication-assisted recovery, and others. Recovery-oriented care offers choice by providing a flexible menu of services and supports designed to meet each individual's specific needs. Secondly, with a self-directed approach, a recovery-oriented system encourages and supports individuals in exercising the greatest level of choice over their service and support options and responsibility for their recovery. Next, with a strength-based approach, this system identifies and builds on the assets, strengths, resources, and resiliencies of the individual, family, and community, rather than emphasizing needs, deficits, and pathologies. Last, this system includes the participation of family members, caregivers, significant others, friends, and community who play such an important role in the recovery process. These individuals are incorporated, whenever appropriate, in recovery planning and recovery support. Additionally, A recovery-oriented system of care recognizes that these individuals may have their own needs for supports or services. In addition to the values underlying a recovery-oriented system of care, there are specific operational elements which will be described here. First, collaborative decision-making is utilized. This system provides information to individuals and families so that they can make decisions and choices regarding their care. Individuals are empowered to collaborate with professionals, peers, and other formal and informal service providers to direct their own recovery to the greatest extent possible. A recovery-oriented system of care also offers a broad array of individualized and comprehensive services and supports to meet the holistic needs of the individual. Services are designed to support recovery across the lifespan, with the understanding that needs and resources shift and change with age and life stage, as well as over the course of recovery. Services and supports should be gender-specific, culturally relevant, trauma-informed, family-focused, and appropriate to the person's stage of life and stage of recovery. A recovery-oriented system is also responsive to and draws on the resources of the community. A recovery-oriented system offers a range of services and supports by drawing on the strengths, resilience, and resources of the community, including professional and non-professional organizations and groups, such as community-based service agencies, recovery community organizations, faith-based organizations, schools, civic groups, and others. A recovery-oriented system coordinates services and supports to ensure ongoing and seamless connections within and among various organizations for as long as the individual needs them. In addition, there is multiple stakeholder involvement, meaning that this system involves all segments of the community, including treatment and recovery professionals, policymakers, administrators, people in recovery, family members, representatives from allied health and social service agencies, community leaders, and others with concern for substance use disorder recovery. It promotes trust and transparency in the design and delivery of services and supports. A recovery-oriented system includes members of the recovery community in the design of systems, services, and supports. People in recovery and their family members, caregivers, significant others, friends, and other allies are included among decision makers and have a meaningful role in service design, provision, and quality improvement. Peer-to-peer recovery support services are included in the array of services offered. Outcomes are measured to improve the systems of care. And lastly, a recovery-oriented system leverages and coordinates federal, state, county, and municipal funding, which is maximized to allow flexibility in providing a menu of service options. While some may view a recovery-oriented system of care as a long-term model of recovery, it's actually designed to incorporate the entire continuum of care, from prevention to intervention to treatment to post-treatment. The overarching goals of recovery-oriented systems are to prevent illness, to intervene early, to support recovery, and to improve outcomes for individuals at risk of or already experiencing substance use and mental health disorders. To help distinguish recovery-oriented systems of care from the conventional system of care, this slide shows a comparison of the fundamental elements of each system. While the conventional system has the emphasis that providers are the experts and can fix the individual, recovery-oriented systems operate with the belief that the individual is the expert in his or her own life, and therefore, services are individualized based upon that person's unique strengths, needs, and circumstances. The conventional system, on the other hand, offers a set of cookie-cutter services, such that plans of care often look identical, regardless of the strengths and needs of the individual. Individuals are expected to choose from a limited array of services, and at times, services are prescribed by the provider without the individual having any input. In a recovery-oriented system, There is a strong emphasis on choice, and a broad array of supports and services are offered. The focus in a conventional system of care is to reduce the symptoms associated with the individual's mental health or substance use disorder, or to manage the symptoms. In recovery-oriented systems, individuals are encouraged to live a meaningful life and strive to recovery in all aspects of life. This is achieved in many ways, with a huge piece being through the development and enhancement of family, natural, and community supports versus a reliance on the professional services or system in the conventional system. Lastly, while the conventional system bases services around the individual's identified deficits, recovery-oriented systems focus on an individual's strengths, assets, and abilities. These are the references used to create this chapter. The module is now complete, and you can proceed to the quiz.